Welcome everyone. Today our topic of discussion is the approach to HPLC interpretation. So this lecture is mostly based on the HPLC interpretation when you get an HPLC curve. I will not go too much in detail about the hemoglobinopathy physiologies or pathologies or any technical details of HPLC. Just when you get an HPLC report, you should be able to interpret it. So first we will start with the normal hemoglobin HPLC. So there are two important terms in HPLC. One is retention time and one is retention window. So how do you understand that which hemoglobin is present in how much percentage in a HPLC curve? So you have to be well acquainted with the retention time. Like the first it comes the HbA, it is around 1 minute. This is the retention time of HbF. But what is the retention window? Retention window is in different machines, it will not every time it will come like 1 minute 0.8 second. So the retention window is within that window anytime that hemoglobin can elute. That is 1 to 1.3 minute to 1.3 minute is for HbF, followed by some minor peaks like P2 and P3. And P3. P2, P3, the retention time is 1.45 minute and 1.75 minute respectively. And now the main hemoglobin is HbA, which is the most common hemoglobin variant we get in the HPLC curve. It is HbA or HbA0, which is called. The retention time is 2.6 minutes and the retention window varies from 2.2 to 3.30 from here to here. Followed by that, the next HB hemoglobin is HbA2, which the retention window of that is 3.83. The retention time is 3.83 and the retention window is from 3.68 to 3.98. After that HbA2, just adjacent to the HbA2, we can get a D window. In normal person, we won't get it. But in abnormal hemoglobin variant, like in the presence of HBD Punjab, we can get here a peak. The retention time of this D window is 4.05 minute and the retention window can vary from 3.98 to 4.12. Followed by that, there will be S window, like for HbS. It will come between 4 minutes to 5 minutes and the exact retention time is 4.27 and the window is 4.12 to 4.43, somewhere like this. The window is 4.12 to 4.42. It can go till 4.45 etc. And the last peak is of HbC window, where HbC elutes. It's just adjacent to 5 minutes. And the retention window is 4.88 to 5.18 for HbC. Okay, so altogether we can get this many peaks here. And there is a term called area under curve. Then what is the area under curve? In for every hemoglobin variant, you will get a peak. So there will be a curve and the area under curve. This area under curve will decide that how much percentage of the hemoglobin is present in that sample. So first you have to decide that which hemoglobin is present, which hemoglobin variants are present and you will decide it by the retention time and the retention window, and that hemoglobin variance is present in how much percentage will lead you to the diagnosis of the hemoglobinopathy. We will start with this one. Mostly, you should know or remember the retention window, but in a normal HPLC graph, along with the graph, all the retention time and percentage counts. So, as you can see that here for every curve like P1, F, P2, P3, the retention time has been given and the area under curve are also have been given, and depending on that area under curve, they have decided the percentage of the hemoglobin which are present. So here you can see that the main bulk of the hemoglobin variant is HbA here, that is comprising of 75.9%. Followed by there is A2, that is 8.8%, and HbF. Now, what is abnormality here? Abnormality is being the A2 percentage in a normal male, in a normal person, it can vary from 2 to 3.3 mostly. We can take till 3.5, but if it is more than 3.5 or if it is less than 2, then those are abnormal. Of course, this hemoglobin, this HPLC curve is abnormal because it has a higher HbA2 of 8.8, and also you can see that the HbF is more. The HbF is here 2.9%. In normal individual, this should be less than 1%, but here it is increased. So, how to interpret this HPLC curve? So, the approach, in a normalized approach, you should see that first you look at the HbA0 percentage. Okay. If HbA0 percentage is there, like it is more than 50% around, this can never be a homozygous hemoglobin. So, if HbA is present in a significant amount, first you have to know that this is something heterozygous. In the previous curve, it is 75.9. So, this is not any homozygous abnormality, this is a heterozygous. Now, what are the abnormalities? So, after HbA, you have to see the HbA2 peak. If HbA2 is within 2 to 3.3 percentage, it is normal. But if it is more than 3.3, sometimes we take it as a 3.5 also. If it is more than 3.5 till less than 10, like 9, then this is heterozygous beta thalassemia. Okay. If it is more than 10 to 20%, we call it HB lipo. But obviously heterozygous. Okay. If it is more than 20% to 35%, it will be heterozygous HbE. If it is more than 40% to around 50%, it will be heterozygous HbE Iran. And if it is more than 70%, it will be homozygous HbE. Now, why all the variants, all the percentage can be heterozygous, but when it is more than 70%, it is homozygous. Because if the HbA2 peak, like HbE peak, is more than 70%, obviously the HbA can't be more than 50%. It will be less than 50%. So first you see if there is significant amount of A. If there is not significant amount of A or it is almost nil, it will be a homozygous or compound heterozygous. What is compound heterozygous, that I will discuss in my subsequent lectures, but that won't be heterozygous. But if there are significant amount of HbA is present, it will be a heterozygous abnormality. So going back to the previous one, so I told that if it is more than 3.5 to 10 or less than 10 or 9, it will be heterozygous A beta thal. So what is this hemoglobin HPLC tells you? That this is a heterozygous variant because HbA2 is in a significant amount. So this is heterozygous and A2 is less than 8 but more than 3.5. So it is heterozygous beta thalassemia. Okay. So moving forward to our second curve. Now, just as I have already told, you have to first see the HbA. How much percentage of HbA is here? It is 8.9%, a very minor amount. Okay? So this is not a heterozygous variant. So mostly this is a homozygous. Now the A2. A2 is also mildly raised. It is more than 3.5. This is 4.6% here. Okay. But what is the significant amount of hemoglobin variant is here present is HbF. This is 81.6%. So whenever you get like this curve where there is a significant amount of HbA followed by HbA2, but there is almost nil amount of HbA or very minute amount, this is a homozygous beta thalassemia. Obviously, if you dig into it, there can be other differential diagnosis also, like hereditary persistence of fetal hemoglobin. But obviously, in a normal person, it's rare. In a normal person, you won't get a hereditary persistence of fetal hemoglobin. That is called HPFH. And also, an HPFH person will not present with an anemia symptoms and they will not require any transfusion. Obviously, anytime you get an HPLC report, you have to correlate with a history. So if you get this curve and the presentation is like the patient is needing recurrent blood transfusion starting from the very early age, like 6 months or 8 months, and the peripheral smear is like very much microcytic hypochromic, etc. And also there is a family history, you will straightforward tell that this is a homozygous beta thalassemia. But if it is not there in a normal person, not presenting with anemia or never required any blood transfusion, but just on a incidental HPLC, you have got a high HbF peak, and where but patient has no other symptoms, almost asymptomatic, you will think about in mind about HPFH. There are many interpretation of a high HbF values, but we will discuss it later on because those are very intricate details of HPLC interpretation. Okay, then moving forward to our next curve. In this curve, again, we will start with HbA. So you can see that the HbA is more than 50%. It is 59.2. So what is this curve? First, obviously, this is a heterozygous. Okay. Followed by that, what is the next value? Is the 24.9 of A2. But we told that if it is more than 20% to 35%, it is heterozygous HPE. So this is heterozygous HPE. Because there is significant amount of A followed by a 24.9% of the HPE. It can be confusing sometimes because many peaks co-elute in the HB at the place of HbA2, but you have to remember the percentage. Like if it is less than 10, but more than 4, it is heterozygous beta thal. If it is more than 10 to 20, it is lipo. If it is more than 20 to 35, it is heterozygous HBE. It is more than 40 to 50, this is HBD Iran. And later on, if it is more than 70% or the main chunk of the hemoglobin variant is in the HbA2 peak, then this is homozygous HBE. Okay, so you have already diagnosed this is as heterozygous HBE. Going forward to the next peak. Okay, so here also first what we have to see, A. The A is very much less here, it is only 3.4%. So obviously this is not a heterozygous variant. This is homozygous. Followed by what is the main bulk of the hemoglobin variant here? That is A2 peak. In A2 peak, we have got 77.5% here. So if it is more than 70% in the A2 peak, what will it be? It will be homozygous HBE. Okay. So mostly we have already discussed about the heterozygous variants of beta thal and the homozygous beta thalassemia, and also a different interpretation of HbA2p. Hopefully you have understood that. So now we are moving forward to the other peak than the HbA2. Again, whenever you get an HPLC, your approach should be the similar. There shouldn't be any difference in your approach. First, you have to see the HbA peak, followed by HbA2 peak, and second and thirdly, other hemoglobin peak. Okay, so here you have got a peak 54.5%. So what will it be? It will be an heterozygous variant. After A, what are the other peaks which are important? Here they have given S window. Okay, S window, what I told you, like the retention window is varying from 4.12 to 4.42. Here the S window is in 4.42, the retention time. Okay, and the second most common percentage is the HbS. Along with that, there is a mild increase in HbF also. The HbF comprises of 10.8%. Okay, so there can be two possibilities here. Like first possibility, that it can be a heterozygous HbS plus beta thal. Why beta thal? Because this increase in F can be due to a coexistent beta thal, and it can be a compound HbS plus beta thal. There is an option that it can be HbS heterozygous simply. Okay. Then which curve will help, which peak will help us now? The peak which will help us now is A2. If there is a coexisting heterozygosity of beta thal, then the A2 will be more than 3.5%, mostly more than 4, 5, etc. But here the HbA2 is 3% and it is well within the limit. So this gives us the clue that this is not a compound heterozygosity. This is actually a normal, a simple heterozygosity of HbS. But if this curve would look like this, like increased HbF, a significant amount of HbA, around 6% A2, and almost similar HbS, like 26%, this would have suggested this diagnosis of compound heterozygosity of HbS and beta thal. But but then also we couldn't call it directly a compound heterozygosity. We should have done a family screening or a parental screening, because a person to have a compound heterozygosity, one abnormality should come from one parent and one another abnormality should come from another parent. So if the parents show that a person, that one parent like father or mother is having a normal HPLC and the other person is having HBS, then it can also be a simple heterozygous HBS, because some adducts or acetylated products of HbAs can also coelute at the A2, giving a false rise of HbA2. This false rise can reach up to 4-5%, but not more than that. Of course, if the HbA2 is around 6%, 7%, 8%, and also there is an increase in HbAs, our first diagnosis should be a compound heterozygosity for HbAs and beta thal. And if the A2 is around 3.5 or well within the normal range, 3.1 or 3.0, then it is a simple heterozygosity for HbAs. Next, we have got this curve. First, we will see A percentage. It is 1.9. It is very low. So, of course, it won't be any heterozygosity. So, what will it be? It will be a homozygous variant. So, what is the main bulk of hemoglobin variant here that has diluted in the HbAs window comprising 72% is HbS. Here. And also we have got the increased amount of HbF. As we have already discussed in a previous slide, based on that we can see that whenever there is an increase in F, we have to look for A2. This A2 level is here 2.5% and it is well within the normal limit. So, this is a homozygous HbS disease. If this, now the question arises, why there is increase in F? You have to remember that in homozygous HbS, the HbF can also increase. It can reach up to 20, sometimes 25%. This is absolutely normal with a homozygous variant of HbS. This can also be a compound heterozygosity, but again, to call it a compound heterozygosity, the HbA2 should be significantly increased. There are other variants also, other rare variants like HBC disease, HBD Iran, HB Lepore, and HBD Punjab, which I will discuss in my subsequent lectures. Thank you.